Good morning. Hi, I'm Eric Roselli. I'm the director of the Aortic Center at the Cleveland Clinic Heart and Vascular Institute, and I want to share with you a paper we recently presented at the 99th American Association for Thoracic Surgery in Baltimore, Maryland. This study asked the question of what is the risk of adding aortic replacement to cardiac surgery, a study that was led by Jay Idris, one of our research fellows, and it's a really remarkable work. We are seeing more and more patients that require multi-component operations that involve their valves, their coronaries, their aorta, and arrhythmia problems all at the same time when we do heart surgery. And many of those patients do have a dilated ascending aorta or an aortic aneurysm associated with several other problems that are bringing them to the operating room. And so we asked the question, does adding aortic replacement to cardiac operations increase the risk of the surgery? Well, we started with a series of patients over a 5-year period, over 14,000 patients, which included nearly 1,700 who had aorta replacement as part of their operation. And we had the CAT scans and all the details and imaging analysis of those CAT scans on the aorta patients included in the many variables that we collect on these patients. And we did a comparison of those two groups. But we did a fair comparison where we did what we call propensity matching. And that is, you can see in the green, we found people who were similar based on many of those variables, except for whether they had their aorta replaced. And when we compared those similar groups, we found that there was no difference in death or several of the other complications, but there was a slightly increased risk of stroke in the patients who had aorta replacement, about 2.5% versus 1.5%. Well, we wanted to look further at why we thought that stroke risk might be higher in that group of patients undergoing aortic surgery, because we know this does involve a complex population of patients. And so we did another propensity analysis. This time, within that aortic group of patients, we broke them up into those who had circulatory arrest, that's when we cool the brain down to a very cold temperature, and to those where we did not use circulatory arrest. And sure enough, we found that the half of those groups who had the circulatory arrest, the risk of death and stroke was a little bit higher, still well under 5%, but nowhere near these remarkable results of 1% or less in the other group of patients. Which raises the question, is it the circulatory arrest that's the culprit, or is that a marker of people with more advanced disease? And so, again, we looked closer at this question because we know that there are some people who require circulatory arrest because it's the only way you can fix their complex aortic problem. And then there's another group of folks where it's part of the technical decision-making during an operation that may be surgeon-specific or patient-specific for other reasons, but otherwise things are equal. And so we looked specifically at that group of patients that had circulatory arrest, and we matched them to the patients without circulatory arrest. And within those 342 similar pairs, which represents the folks where circulatory arrest was more a surgeon's technical decision than it was necessarily a patient's disease issue. And sure enough, we found that there was no difference for either death or stroke. And these results are excellent, where these are rates of less than 2%. And so it seems like circulatory arrest is not necessarily the culprit, but a marker of more advanced disease. Well, then we took that group of patients where we basically corrected for the use of circulatory arrest, 684 patients, some with and some without circ arrest, and compared them again to this large group of cardiac surgery patients. Again, we were able to match many similar patients, 647 pairs. And again, we found that there was no difference in their outcomes. It's really safe. The risk of death was less than 1% in either of those groups, with or without ascending aortic replacement, and the risk of stroke was in the 1% range in both groups. Outstanding results from our very experienced team. And so to summarize this study, we did 3 complex propensity match analyses where we correct for some of the biases included in the fact that these people are a broad spectrum of people with a lot of different presentations. And we came to the answer that there was no difference in mortality or stroke when we add ascending aorta replacement to the operation. The group of people that weren't matched also did well. They had very advanced disease and bigger aneurysms, and their risk of death and stroke was still well below the 10% range, which is better than predicted at most centers. What this tells us is that when patients come to the operating room and they have multi-component problems with their valves, their aorta, their coronary arteries, we can do an operation to address all of those issues at the same time, even if it includes replacing the ascending aorta very safely without adding risk. And that means that we can give these people a good long-term survival, and their chance of having to come back to the operating room within a decade or so can remain low. And once we get people through these multi-component operations, we know that our medical care is better, their blood pressure is getting treated better, their other comorbid problems are being treated better. And so we're not only prolonging lives, but we're likely reducing the chance that people need to come back to the operating room for additional cardiovascular operations, because we can handle them all at one time with our very experienced team. Thank you for your attention today.